Thank you, Dr. Fayella. Thank you, Dr. Clem. And good morning, everyone, and welcome to what I'm confident is going to be a fantastic next 2 days. You know, it dawned on me that there's probably a few of you out there wondering, you know, what in the heck does periodontics have to do with health, beauty, and prosperity? And why should we really care? Well, you know, the most popular, most visited websites in the entire world center around these three subjects, giving irrefutable evidence that these commodities are important to people all across the world. And I'd like to share with you how periodontics can improve the health of our patients, the beauty of our patients, their quality of life, their well-being. And let's also look at how periodontics and periodontists can enhance the prosperity of our restorative team through a collaborative approach. Now, prosperity in this context means not only financial success, but also happiness and a sense of professional well-being. In order to do this, it's going to take a team effort. It's going to take the patient, it's going to take the perio office and the restorative office working together to achieve excellence, and that's exactly what this conference is about. It's been my experience that it's not always easy, but it's always worth it. I couldn't be any more proud of my specialty of periodontics. When I was in my residency about 35 years ago, it was a pretty narrow specialty. In fact, looking back on it, I wonder, why did I go into that at that point? You know, we only treated 1 or 2 diseases. We had very limited treatment modalities. We had root planing and scaling, flap osseous surgery, and the non-root coverage graft. Unfortunately, there's a sizable segment of dentistry out there that still thinks that's all periodontists do. You know, we sometimes hear somebody say, you know, well, I have a hygienist, so why do I need to work with a periodontist? By the end of this conference, you'll be clear the benefits of working together as a team with a periodontist. You know, we still very much appreciate being able to prevent disease, to maintain the natural dentition in health, comfort, and function. That's what periodontics has always been about. That's what periodontics is still about. But we also have a far greater knowledge now of the relationship between periodontal disease and systemic disease. If we're not successful in maintaining the natural dentition or tissues, we now have wonderful ways to replace those. We're constantly improving our diagnostics, our risk assessments. We've got great new ways to go in and regenerate hard and soft tissues, especially as we move into tissue engineering. We're constantly improving implant site development and placement techniques. Treatment of periodontal diseases and implantitis continues to progress, and fantastic perioesthetic procedures, and a lot more. And you're going to see all of these things in the next day and a half. Now, one thing hasn't changed over the last 35 years is effective periodontal therapy sets the stage for restorative success. Now, how we get from A to B may have changed in that time, but I think all of us can appreciate that we want a periodontium without inflammation, with minimal probing depths, adequate keratinized tissue, stable occlusion, mobility within normal limits, appropriate tooth lengths and gingival contours, a healthy biologic width, elimination of pigmentations or tattoos, full of papillas and intact dentitions. You know, those benefits, I think, are enough to move all of us forward. We have to remember, though, that most of the time those benefits are not enough to move our patients into action, because our patients really don't care about connective tissue grafts, and our patients don't care about veneers, but our patients very much care about the benefits of veneers and the benefits of connective tissue grafts. So for us to be successful, what we have to do is find out what benefits are important to our patient that's sitting in front of us. And we can't do that by talking. We've got to do that by listening, asking open-ended questions, identifying what benefits are important to our patients. And once we know that, then we can present our treatment in terms of what's important to our patients. Because as hard as it is for us to believe, our patients may not be interested in no inflammation or minimal probing depths, but they are interested in preserving bone, health, wellness, eliminating disease, fresh breath, enhanced quality of life, peace of mind, make more beautiful, youthful, comfort, self-worth, confidence, being sexy, saving time and money in the future. All of these are here and now benefits that are important for us to find out from our patient and link it to the services that we're going to provide. That kind of leads into thinking also about what business are we really in here. Think about it. Are you in the health business or you in the disease business? Most dentists are in the disease business because that's how we were trained in dental school. But all the trend analysis out there show that is the wrong business to be in. If you get rid of the disease, nobody wants you anymore. If you're in the health business, who doesn't want to be more healthy? Who doesn't want to be more beautiful? In addition to that, we're moving away from needs-based dentistry to wants-based dentistry. More and more of what we do today and will do in the future is based on discretionary dentistry. You know, you cannot reach the level of psychological and financial prosperity that we're talking about doing most of your time treating patients' needs. You've got to be treating their wants in order to do that. And in the absence of pain, bleeding, and swelling, you know what? Our patients don't need us. And there's very few things that are going to be talked about in the next day and a half that our patients really need. But you know what? Most everything we're going to talk about in the next day and a half our patients want. That's pretty nice. That puts us into a good spot. Well, who are these patients that we're talking about? Dr. Clem kind of brought that up a little bit, that for most of us, our patients are the baby boomers. This year, 2011, the first baby boomers turned 65 years old. In 2020, 9 years from now, 1 in 5 of our patients will be 65 years or older. But for this group, living older is not enough. They want to live better, and you know what? They've got the money to pay for it. We are seeing the greatest transfer of discretionary income ever in the United States with the baby boomers. But with this group come different expectations. They want to live better. They're interested in health, wellness, cosmetics, comfort, value in the treatment of your office. They're more self-reliant in deciding who will they allow to treat them and what treatment will they accept. You see, as the world moves from a handshake to a keystroke, our patients are transferring into informed consumers. Informed consumers with an increasing responsibility to select from a wide array of choices. And for us to be successful, we have to be able to provide those choices and to fulfill those expectations. In addition, the baby boomers are coming to us with more teeth than any older generation in history. They're not like their parents who lost most of their teeth as they grew older. This generation is used to coming to you and I. They've grown up going to the dentist. They value what we do. They value prevention. But they're also going to be coming to us with a lot of chronic diseases, and it takes teamwork in order to be able to effectively manage those diseases. Because of that, risk assessment is going to be more important than it ever has been in the past. Risk assessment to manage their current disease, and risk assessment to be proactive to deal with future diseases. You know, risk factors have been important in periodontics forever. Risk factors influence the development, presentation, and progression of periodontal disease. There's a whole list of local factors and systemic factors. I've just listed a couple. You know, as far as pre-existing disease, if you have a patient who has deeper probing depths, they're more likely to have further disease in the future. Plaque retentive areas like defective restorations, of course, we need to replace, and there's a whole list of those. Systemic factors, the two most important would be a poorly controlled diabetic and smoker. But stress can play a role, how you manage stress, osteopenia, a whole list of those. And then, of course, gender. It's felt that perhaps men have more problems with periodontal disease than women, and age, the older you get, the more likely you're going to have periodontal problems, and genetics can play a role as well. Now, when I was in my residency 35 years ago, as Dr. Clem mentioned, everything centered around bacteria, you know. At that point, bacteria was bacteria, and too much of it was bad. And definitive care consisted of creating an environment that allowed us to perform effective plaque control, both for the clinician and the patient, and good daily home care. Now, bacteria remains important. It is bacterial biofilm that causes periodontal disease. But many scientists and researchers are saying today, hey, forget the bacteria, control, or better yet, eliminate the inflammation. It seems this out-of-control inflammation is the engine that is driving this ever-growing list of chronic diseases. There's no better example than the problem of than inflammation's problem of friendly fire and systemic consequences than what we see with chronic adult periodontitis. Chronic adult periodontitis is a bacterial disease. It's caused by bacteria, but at least 2/3 of its destruction is caused by the inflammatory response to the bacterial invader. And to make matters worse, it doesn't seem this inflammation is localized to the mouth. Now, in the mouth, it of course manifests as redness, swelling, suppuration, bleeding on probing, all the things we've been taught about inflammation. We know these are never acceptable. We cannot leave these. If we do, it leads to hard and soft tissue loss. If we leave them, it leads eventually to tooth loss. But what we didn't understand is that if we leave it, it also increases the systemic inflammatory burden. That then leads to what we're becoming more aware of, that there is this periosystemic link. And there's growing evidence that chronic adult periodontitis puts us at risk for a whole host of chronic inflammatory diseases: respiratory disease, osteoporosis, chronic kidney disease, rheumatoid arthritis, cardiovascular events, diabetes, a lot more. And some of these can be bidirectional. You know, if you have a patient who is diabetic and has periodontal disease, if you eliminate their periodontal disease, it may make their glycemic control better or easier. Opposite of that is if you control their diabetes, it's going to be easier to bring their periodontal disease under control. The shocking discovery that the mouth is somehow connected to the rest of the body is changing everything out there. I mean, it's kind of the wild card that's floating around out there. We're beginning to understand that we need to think of chronic adult periodontitis as one of the chronic diseases of aging that has inflammation as a common denominator. That's why it's so important for all of us to be performing a comprehensive periodontal evaluation every year and a definitive reevaluation at an appropriate time in your treatment. Only through that can we really create the appropriate diagnosis and assign appropriate prognosis to both teeth and implants. The problem out there is, you know, there's no generic patient. Everybody's different. And a patient with furcation and vertical defects, they're going to be at higher risk than somebody with horizontal bone loss and no furcations. These people need to be identified earlier, and they need to seek sophisticated care earlier. A patient under 40 years with moderate perio probably is going to be more difficult to control than a patient at 60 with moderate perio. There is more periodontal disease out there than any of us can treat. The trick is, how do we identify those people? How do we triage those people so that we know who is safe to treat in our office and who needs more sophisticated care? We need to be able to triage. You know, a patient with less than or equal to 4 millimeters probing depth, obvious bacteria etiology, systemically healthy, limited tooth mobility, no furcation involvement, that's a great patient to keep in the general practice. But a patient with persistent inflammation, greater than 5 millimeter probing depth, furcation involvement, intrabony defects, especially vertical, and mobility, those are people that would really benefit from not only referral, but referral early in the process. People like this. You know, we have gotten so excited about implants, and implants are wonderful. Where would we be over the last decade without implants? But it's almost overshadowed the excitement that we also have in new regenerative techniques. You know, here, one of my patients, you see on the far screen here, our pointers don't work on this big screen very well. But at any rate, I think you can tell we've got a significant vertical defect there. You can appreciate there may be some calculus on the root surface. And so just by performing open flap, I remove the granulation tissue, remove the calculus, and in this case I grafted it with platelet-derived growth factor. And look at the radiographic consolidation at 36 months. We've completely eliminated the defect. There's even suggestion that the furcation involvement looks better. We have 6 millimeter probing depths. We can do that. But this is not the patient that you want to continue to root plane and scale and squirt local, delivery antimicrobials down in here. Because if this bone loss approaches the apex down there, and that's just a few more millimeters, it makes such a big difference in what we can do regeneratively. So these are the type of patients that are going to benefit from early diagnosis and referral. Bottom line is periodontal therapy works. With appropriate diagnosis and treatment, we can maintain teeth for many, many years, hopefully the lifetime of that patient, even those teeth that have a poor to questionable prognosis. So there's no doubt that working together in a collaborative approach, we can help our patients' general health as well as their periodontal health. But I also said periodontists do a lot more than just treat disease. So let's look at the full scope of periodontics. We'll do a little quick tour here. Some of this is going to be covered by the speakers in the next day and a half in great detail. Others will not be covered just because of time constraints. One thing that is a great thing that perio can do with the restorative office is aesthetic crown lengthening.
The thing that bothers me the most is this gum. This is really low. My front left tooth, I believe, was the one that, like, the gum line came real low, and then the right tooth, the gum line was real high. That's what caught my eye.
Dr. Michael McGuire moves the gum around each tooth to give his clients a structurally sound smile.
The gum is kind of like the frame around a picture. And you can have the most gorgeous picture, but if the frame is off, then it distorts everything.
So, you know, she didn't have to have this little surgical procedure or have to have those new restorations. But through very simple flap osseous surgery, we can go in and raise the tissue if the patient has a gummy smile or if they have tooth length discrepancies like this. And what that allows us to do is set the stage so that people want discretionary dentistry. You know, it allows us to do the things we like to do. It certainly helps our bottom line. And in her case, it benefits her by making her more beautiful, youthful, self-worth, confidence, enhances her quality of life, sexy. You know, these are easy sells. Functional crown lengthening, not quite as easy of a sell, but just as important. You know, we had a dinner discussion last night with the restorative group that we brought, and one of the things that we talked about is how nice it is to be able to do dentistry in a healthy periodontium that's not bleeding, that's not inflamed. You know, if you need to make certain that you're maintaining enough tooth length so you don't impinge on the biologic width, like the top slide there where you see all the inflammation. You know, these veneers were placed too close to the bone, created all the inflammation. You don't have to get into that. Just respect the biologic width. If you need tooth length for retention of a fixed restoration, or you need to have a nice ferrule, you know, it's not a big deal. Work with your periodontist, get appropriate tooth lengths before you move into these restorations. Free gingival grafts. You and I might argue how much keratinized tissue we need, but I don't think we're really going to have much argument on about do we need keratinized tissue around teeth and implants. We do. It prevents further recession. It allows us to eliminate inflammation in the presence of good home care. And look at this patient that I did years ago. This side has a free gingival graft. The other side I haven't grafted yet. And what you see there is chronic inflammation that's not associated with bacteria. There's no bacteria there, but the inflammation is there because we don't have a biologic seal. We don't have a nice zone of keratinized tissue. Certainly if you're going to do restorative dentistry, you need attached gingiva to withstand the rigors of intraclavicular margins, the rigors of impression technique. And with today's techniques, free gingival grafts are far less invasive than they've been in the past. Root coverage grafts, wow. You know, this was not something that we did when I was going in my residency, but fantastic procedures, tremendously predictable. We can now go in, you know, your patient's getting long in the tooth. Think about it. You know, we can cover these. We can turn the hands of time back. Of all of the periodontal procedures out there, these are done more times than not because of patient desire, because of sensitivity, because of cosmetics. They don't like them. You know, I appeal to you, please work with your periodontist to allow them to put tissue over this. I was so upset I read this article in one of these dental throwaway magazines a month ago about a new pink flowable composite. The whole article was about putting this pink flowable composite on stuff like this. Don't do that. You know, let's put back what's supposed to be there. And we're not creating pockets. You can't probe this stuff. And it's dimensionally stable. They last, you know, this has been done since the mid-'80s, and they're still looking just like they did in the mid-'80s. They also will get us out of trouble. Here's a patient who has a fairly new bridge. You can see on the lateral incisor retainer that they've had some recession a couple of months after the bridge is done. Now, what are you going to do? You're going to go in and have to remove your brand new bridge? And if you do, are you just going to chase that up there so you have a longer and longer tooth? No. You know, I just go in, do a little connective tissue graft, bring that tissue down over that exposed margin, everybody's happy. So it can get us out of trouble as well. We can do tissue replacement grafts. You have a patient with a broad smile, big amalgam tattoos from a lot of failed endodontics, no problem. Come in, remove that, replace that tissue. That can be a monster issue for patients with high lip lines. Ridge augmentations, whether it's around teeth or implants, also great to get the appropriate soft tissue profiles. You know, here we've got a significant alveolar defect. I just make a little incision in there. I usually, if the tissue's there, I'm going to take it from the tuberosity, and I tell the patient it's like I'm going to put a pillow in a pillowcase. It's going to plump it out there. And that then allows you to have a very believable emergence profile of your ponic or an emergence profile of your implant, and it closes down that open interproximal space. Speaking of open interproximal spaces, one of the most challenging things we do is papilla reconstruction around implants and teeth. Here's one of my patients that even though I did the extraction and ridge preservation, she had such tremendous bone loss. You see lots of hard and soft tissue loss here. And the key to this case is to be able to rebuild this tissue, this papilla. Well, it took a few surgeries, but not only were we able to rebuild enough bone to place the implant, but to rebuild this large volume of tissue here on the mesial, this lateral incisor. You know, that makes or breaks the aesthetics of the case. And this patient has a high aesthetic demand and a relatively high lip line. Same thing here. This lady underwent a regenerative procedure between her central incisors. The regenerative procedure worked pretty good, but she lost her entire papilla. High smile line. I'm not kidding you when I tell you she is on the verge of committing suicide. She cannot live her life like this. Took me a number of surgeries to do this, but she would have done 10 more and gladly paid me for every one of them because this is such a high value procedure for the patient. Benefits are clear. Extraction and ridge preservation. You know, in our office, it's standard of care. We never take a tooth out that we're not placing something in the extraction socket, and that we're not working closely with our restorative colleagues so that we can immediately place an ovate ponic into there. By doing that, we're able to maintain the volume of bone that we need, and by working with our restorative colleagues so we have an ovate ponic ready to go in, we're maintaining a sharp facial free gingival margin and our papillas. That then allows us to move into what I was going to title this simple implant therapy because I'm about to get into some more complex, but as I really thought about it, is it really that simple? I mean, it's not rocket science, but the restorative group and the perio group, we all have a lot of little variables that we have to take care of to get in a result like this where you can't distinguish where the implant-supported restoration is. It happens to be this cuspid. One of the things that allows us to get there, though, is we have a nice broad ridge because we did do a ridge preservation. Not all of them are like that. Look at this ridge. Here we have just a lingual cortical plate. No medullary bone, no facial cortical plate. Wasn't a few years ago, this patient would be flat out of luck. But today, with our periodontal regenerative techniques, I can take a block of bone from the chin, I can move it up here, I can use a little growth factor, and we're able to generate enough bone that we can come in and place not a small implant, but a regular size implant there. Again, think about the patient value here. Now she can have a single implant-supported restoration, easy to clean, very aesthetic, not involving the other teeth, and with our regenerative procedures, this is not necessarily easy, but it can be done. How about sinus lifts? Again, this used to be a fringe procedure. Now this is one of the most predictable regenerative procedures we do. Now, we don't do it every day, but we certainly do it every week. And again, think about it. You're placing implants where there was just air not long ago. Still blows my mind sometimes. And with the use of growth factors, we can place these implants earlier and load them earlier than we've ever been able to in the past. Again, tremendous benefits for the patient, giving them fixed posterior support. You know, it's incredible. How about implants without augmentation? You know, the all-on-4 kind of approach. You know, this is touted as something to save time and to save money. You know, money in regeneration. You know, you don't have to do bilateral sinus lifts and lateral block grafts and all that. That's correct, but to me where this really comes into play is more the time, not the money. You know, our patients are not cost conscious, our patients are value conscious. And in the United States today, time is the #1 most sought after commodity. There's a lot of people that could afford to have all that regeneration, but there's a lot of people out there who don't want to wait 1.5 years in the process. So, you know, here's a patient of mine that was in the office a month or so ago. I take all of these periodontally hopeless teeth out. The same day, I place 4 implants in the lower, 4 implants on the upper. He leaves with fixed hybrid restorations. Again, think of the value here. And also, you know, we are the American Academy of Periodontology, so I'm going to put in a plug for periodontists. All you restorative offices out there, think of periodontists to do this. You know, many times you're thinking of periodontists to send your single tooth implants, your, you know, a few implants. Oftentimes we get the hard stuff. Periodontists can do this just like oral surgeons. I like to think we do it better because we have better knowledge in occlusion and maintenance of the case. Periodontists are the leaders in computer-guided implant placement. You know, we don't ever place full arch implants without computer guidance. I never go around the corner without computer guidance. Talk about a collaborative approach. We can sit there, we can work up our treatment on the computer, we can email that back and forth between offices, we can tweak this, tweak that, we all come to agreement, the patient comes to agreement, the computer guide is made, you go into surgery, bang, 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 implants are placed with great precision, and in this case my patient's leaving with a final restoration the day those implants were placed. So there's no doubt in my mind that if we can incorporate the full scope of periodontics and the restorations that it generates, there's no doubt that that's not going to lead to prosperity for us all. But there's also ways that you can create restorative opportunities that you couldn't do if you were not working with a periodontist. And that relates to the macroaesthetic elements of the smile. Now, microaesthetics, those are the things that make teeth look like teeth. You know, the porcelain, the color, the incisal edge translucency, the surface characteristics. The macroaesthetic elements, that's the shape of the teeth, the position of the teeth as it relates to the face, the tissue around the teeth, the arrangement of the teeth. Too often we forget about the macroaesthetic elements. This lady is a good example. She lost this tooth and a lot of hard and soft tissue a decade ago. She had this bridge placed immediately afterwards. She's hated this bridge since the day it was placed. She calls this her horse teeth. She has had at least 6 dentists suggest that they replace the bridge. She hasn't allowed it. And why is that? Because they've only suggested the microaesthetic changes. Better color, better translucency, all of those kind of things. Now she likes that, she's interested in that, but that isn't what she wants fixed. She wants her horse teeth fixed, and that's not going to change it. Once she understands that we can come in and we can cover these previously restored root surfaces, we can bring tissue down over previously restored root surfaces, now she's interested. And there's even lots of, not just restorative docs, but a lot of periodontists that don't really even think about doing this. That, you know, we used to think that if there was a big butt joint margin up there, you know, the fate is sealed, you can't do anything. But today we can bring that down. We can cover these root surfaces that were previously restored. This is the case that started it all in my office in the mid-90s. She came to me with this provisional bridge in place, and she had just been to her dentist the day before, had the provisional placed. She went to the bathroom on the way out to the dental office just to freshen up, and when she looked at herself in the mirror, she was aghast, and she went back to the receptionist, could I visit with the dentist again? And so they got her back, and she said to the dentist, well, my real bridge isn't going to look like this, right? And the dentist assured her, no, the color's going to be a lot better. It's going to match this. She says, well, that's fine, but this tooth right here, it's not going to look like that, right? And they said, well, of course, you know, you had recession, we had to cover it. And the lady said no. So, you know, she comes to our office, I remove the provisional bridge, shorten the provisional to ideal tooth length, do a little partial thickness flap, here's our butt joint margin, flame-shaped finishing burr. We're going to do a little Texas-style root planing and scaling here. And so I'm going to remove that margin. You then later can reprepare it at the proper tooth length, little connective tissue graft, coronally advance the tissue, And now we have this. Here it is at 6 months. I'm probing. You can see the tissue blanching. That is the 1 millimeter mark, 2 millimeter mark. So we're not creating pockets, but most important, what we are creating is an environment that allows us to be able to create restorative opportunities. Another patient. Here we've got tooth lengths all over the map. You've got crowns that are way long. You've got all these class 5 restorations. You might not even offer this patient a choice. I mean, how would a person get to this point if they were interested? Well, this isn't dental neglect, it's option neglect. Nobody's ever told this patient what the possibilities are. So let's remove the class 5 restorations. You can graft down over those. Let's determine what proper tooth length and gingival contours are. Let's remove the crown so we can bring the margins down chair side. And through a combination of grafting and restorative works, we can create the restorative opportunities. I absolutely guarantee you that if you go back and you start looking in your maintenance program and your new patients, you're going to see all sorts of people who would love to have old restorations replaced if you can show them how you can change the macroaesthetic elements. It'll create a whole new revenue stream for you. Also, by working together, we can also improve prosperity, just simply by working together. You know, I have always felt that my restorative colleagues are my business partners, that I'm only going to be as successful as they are, and anything I can do to make them more successful is going to benefit me as well. But by working together, we can certainly reduce overhead. There's no reason that all of us have to own and maintain all this expensive dental equipment or maintain these extensive inventories. You know, I don't want to have to buy a CEREC machine. I don't want to have to buy a digital scanner. You probably don't want to buy a CBCT. You don't want to buy a piezoelectric surgical instrument. So it allows us to reduce our overhead. It increases our efficiency. You reduce chair time when you're doing things you're good at. It reduces lab bills because if you're working with somebody who's placing implants precisely, your lab bills will be lower. It reduces remakes if you're working with a periodontist so that you have a nice healthy periodontium, you're not having recession. It reduces liability, that goes without saying, for both of us. It increases case acceptance. You know, with us working together as a team, the patient's hearing the same story from both offices. We can even do some co-marketing with our all-on-4 kind of thing that we're doing. For those offices that are interested in that, we're doing co-marketing. You certainly should be doing coordinated patient education. You need to make sure that they're getting the same message at your office that they are in the periodontal office. And it just improves acceptance because the patient understands that they've got two different dentists that care about them and are telling them the same thing, and they're benefiting from the expertise in both offices. It also results in superior outcome. You know, somebody told me a long time ago that, Mike, you can do anything you want to do, but you can't do everything. You can be a jack of all trades, but master of none. A lot of truth to that. Collaborative care will improve the predictability of superior outcomes, but I also have to remind you that superior outcomes are not enough to make you successful. Superior outcomes are what people expect. Superior outcomes are what they're paying for. Value is giving them what they're not paying for. Value is why they're going to travel past 14 other dentists to get to you. Value is what they remember long after what they forgot what tooth you worked on. And a collaborative approach increases the value in their experience in your office. It also gives us flexibility to innovate. It gives us flexibility to increase the scope of our practice without a lot of capital overlay. You know, it allows us all to have options in our practice we wouldn't have if we weren't working together. You know, you might not be able to do work with conscious sedation or some of these sophisticated regenerative procedures that I just showed. I certainly couldn't do some of the implant-supported procedures if I didn't have the prosthetic support. So it goes both ways. It allows us to increase the scope of our practice. And finally, and probably most importantly, it improves our happiness and our sense of well-being. Nothing is worse than if you're doing a procedure that you don't do very often. It starts to go sour. You don't have the instruments that you really need. You start to sweat under your lab coat and you say, oh boy, why in the world did I get into this? You know, we all need to be spending our time doing what we like, doing what we enjoy. That makes us happy, that makes our staff proud of us. We're all doing the dentistry that we do, best. And finally, you know, if you really think about it, by working together, especially in the context we're talking about, it really positions us perfectly in the marketplace. We are together providing two of the most valued commodities in the world, health and beauty, to a customer base, the baby boomers, that particularly value those commodities and have the money to pay for it. You know, life should be good. Periodontics is not standing still. Let me close with just showing you a few of the things that we're doing in our research center. We've been doing studies with live cell technology where we're actually implanting living cells, in this case keratinocytes and fibroblasts, into patients in order to facilitate wound healing and regeneration. The neat thing about this is these are living cells, so they can talk to each other and they can talk to the native cells. So in these studies we've been doing, it's primarily to generate keratinized tissue. We talked a moment ago about why that's important. So here are two teeth, these two bicuspids. You can, I think, appreciate just movable mucosa. This is the living cellular construct. This is the free gingival graft, which is the control. So these are actually living cells here. And at 6 months, I think you can appreciate we've got a nice zone of keratinized tissue from our free gingival graft. This is how we've all been taught that free gingival grafts should look. This is not how free gingival grafts will look in the future. Look at this. We have 4 millimeters of keratinized tissue here. You can't distinguish this tissue from the normal. And that's where we're going. With today's surgical techniques, we know how much root we can cover. We know how much attached gingiva we can do. But with our newer techniques, the next goal is to be able to generate tissue that's indistinguishable from what Mother Nature really intended there. And this can do that because it doesn't work like a graft. It induces the cells that belong there to come in. We're also working with a variety of different materials. We're trying to look for something that will replace connective tissue. This is a study we did with a 3D matrix where we were looking at it for a variety of things. In this case, this is a 4-year post-op where we're covering this root surface with this 3D matrix. Beautiful aesthetics, no probing depth, all done without a donor site. The neat thing about the matrix also is that you can use it in an exposed environment. Very few materials can you use exposed as well as covered. Here this patient has some racial pigmentation she doesn't like, so I'm removing that down to the periosteum. I save that just to act as a pattern to cut around that. I suture it to place. Look at what we've got here. Now this isn't easy. Look at the pigmentation goes into the papilla on the free gingival margin. There's all sorts of potential for recession here. In the past I would have managed this by taking the tissue off, taking tissue from the palate, connected tissue, placing it there. It would have worked, but we would have had a greater chance for recession, and you certainly would have tissue mismatch. Look here. No scar lines, no inflammation, beautiful result, all done without a donor site. We're doing all sorts of studies with growth factors. Here's a study that we published a year or so ago where we actually look at the type of attachment we get. So here is we're going to mark with a high-speed finishing burr at the free gingival margin. Here I've marked at the alveolar crest. In this case, we grafted it with platelet-derived growth factor. 9 months later, we removed the tooth and block. So everybody reach under your table. We've got 3D vision glasses under there. Pick them up, put them on, and I want you to look at this with your glasses, and this is what you see. So this is a micro CT of the tissue. You see you've got 100% root coverage, but here is the bone. You can't see this mark at the alveolar crest because the bone's grown up over it. We have a uniform space for the PDL, and this is the notch at the original free gingival margin. Now I have to say, when I looked at this initially, I thought, wow, that's neat. We grew 2 to 3 millimeters of bone, but I was wondering, why didn't we even grow more? Well, the answer is because that's as much as you can grow. This is such a beautiful slice histology. It looks like an illustration, but this is a slice right through that tooth, and here we have, you see, this is the enamel, and here's our free gingival margin, so 100% root coverage. Here's our sulcus, our long junctional epithelium, ending at the gingival notch, and our connective tissue. So what does that make up? The biologic width. You have to have a biologic width. So we regrew as much bone as was physiologically possible. And if we look at that, this is the dentin, old cementum, new cementum, functionally ordered PDL, new bone. The last one I'll show you is on papillas. You know, the most difficult thing that we can do is to regenerate papillas. Very high value for the patient. Here we did a little study where we tried to look at a novel approach where we took some tissue from the palate, we place it into a medium, we send it to the laboratory. These cells then, or the tissue is broken into different cell lines. The fibroblasts are expanded to 200 million fibroblasts per ml. We then do a little surgical insult to the papilla, causing some swelling. And we go in and we inject around 6 to 8 million fibroblasts into the papilla. These fibroblasts then sit there, produce collagen. They begin to thicken the dermis and close the open interproximal space. So everybody look at the center panel here. I'll show you a time lapse from 0 to 4 months after 3 injections. So this study showed that it's possible, if through further studies we can show it's predictable, we'll be opening papilla parlors next to every Bright Smile shops across the United States. This is a patient that was in the study, and at this point I didn't know whether I was injecting placebo or I was injecting cells. After the study was over and unblinded, these are cells, so I'm injecting around 8 million fibroblasts in the papilla. You can see it blanching. So here she is at day 0, here she is at 4 months. This lady remains in our practice. Here she is at 5 years. I think you can appreciate it. We can continue to get improvement at 5 years. How's that possible if there haven't been any more injections? Well, it's possible because we're not injecting a filler here. We're not injecting collagen or Restylane. We're injecting a protein delivery system, living cells sitting there producing collagen, thickening the dermis, closing the open interproximal space to the limits of the embrasure. So there's absolutely no doubt that in the future we're going to be able to do some super things. But I don't want any of you waiting on the future. Don't sit here and wait for tomorrow. Because today, with us working together, we can provide our patients the hottest commodities in the world. We can work together to improve our patients' health, their well-being. We can improve their aesthetics, their quality of life. And what does that result in? Improved prosperity for us all.